Доброго вечора. Українські радіаційні онкологи, медичні фізики, радіаційні терапевтичні технологи. Слава Україні! Дуже дякуємо, що приєдналися до Modern Brachytherapy course with ABS Experts for Ukraine. Help Ukraine Group, in collaboration with American Brachytherapy Society with Speaker Support, is excited to present the 9th lecture in this course. And the topic of today's lecture is LAN, LDR, HDR brachytherapy. Dr. Zoya Shepil will co-moderate this lecture with me, and she will introduce our two fantastic speakers.
Thank you very much for introduction, Natalia. Today we have two amazing speakers, Dr. Albert Chang, Professor of Radiation Oncology at UCLA, serves as Vice Chair of Surgical Service and Chief of Brachytherapy. He earned his MD, PhD from Boston University and completed residency at Washington University before joining UCSF and later UCLA. Dr. Chang specialized in genitourinary and gynecological cancer with expertise in HDR brachytherapy, having performed over 1,500 procedures. And internationally recognized leaders, he has authored numerous peer-reviewed publications, delivered invited talks worldwide, and served in the ABR genitourinary exam committee. His research focused on combining systemic therapy with radiation and advancing imaging-guided radiotherapy. He has led multiple clinical trials, including NCCN-sponsored dose escalation studies in prostate cancer and in the IMRT co-chair for ERTOC 0924. Dr. Chang received the Prostate Cancer Foundation Young Investigator Awards for work on radiation immunotherapy response in oligometastatic disease. Our next amazing speaker, Dr. Sanjun Park, is a professor at the UCLA David Giffen School of Medicine and the Physics and Biology and Medicine Graduate Program. He also serves as chief physicist of the Brachytherapy Division in the Department of Radiation Oncology at UCLA. Dr. Park earned his PhD in nuclear engineering and radiological scientists from the University of Michigan. He completed his fellowship training at Harvard Medical School, Brigham and Women's Hospitals, and the Dana-Farber Cancer Institute. He actively contributes to the field through the roles in the American Association of Physicists in Medicine, where he serves, and several working groups and the Brachytherapy Subcommittee, as well as the American Brachytherapy Society Physics Committee. Thank you so much for preparing the lectures today. It's an honor for Ukrainian community to have you with us. We are looking forward to your lectures on lung, HDR, LDR, brachytherapy. Podium is yours.
Okay.
Stop sharing.
I'm going to share my slides now.
Yeah.
Great. I'm Albert Chang. It's wonderful, and it's a privilege, to be invited to speak about one of our passions, brachytherapy. Today, I know the title was LDR HDR brachytherapy. I wanted to focus on something that we do a lot here, is high dose rate brachyablation for lung tumors. I think it's a cool concept and it's a cool technique that we do, and I'll go into that. So these are my disclosures, and they're not conflicting with anything I'm going to talk about today. So this is the menu of items we're covering. Number one, why do we do HDR lung brachytherapy? And then we'll go into how we do it, and then some case examples, okay? And feel free, if there's any questions, chime in. Happy to answer it. So why do we do HDR lung brachytherapy? So as you know, with brachytherapy, we can really dose escalate. You hear about things about resistance, but I think if you go to a high enough dose, nothing is going to be radio resistance, and there's no better way to escalate dose, in my opinion, than just putting it right into the tumor or right over the tumor. Because you're putting the dose right into the tumor, you're able to spare the surrounding normal tissues. Like for the lung, for especially, we always struggle with SBRT. How do we give SBRT for central or ultra central lung tumors? We went from SBRT, which was highly toxic, in trials, they show fatalities even. And then we started doing moderate hypofractionated techniques for ultracentral lung tumors, but that's still pretty, we're limited in terms of how much we can give, and the patients still have, pretty horrible side effects like esophagitis. They can't eat, and they get pain and stuff. So, I think it helps us to spare the normal tissues like the central airway, the main stem bronchus, the esophagus, the main great vessels. Also, when you're sparing normal tissue, when you're doing brachytherapy, because the dose is pretty much localized compared to our external beam techniques, it spares the rest of the lung. And a patient with metastatic disease, many of them have asynchronous or metachronous metastasis. They'll have one lesion you treat, and then there will be another lesion down the line. And then if you do 2 or 3 treatments with SBRT, you kind of burn a bridge. You can't give more radiation. They're very limited. You compromise their lung function. So brachytherapy, you're able to spare a lot of the normal lung tissue. I always tell my residents, there was one, I collaborate with our IR docs, and then there was one patient, I think between, he had microwave ablation, cryoablations, and multiple brachy ablations. We treated him like 57 times, 57 localized treatments. He never went on any systemic therapy. He lived for like 10 years. And then he wrote his own case report for us to publish. It's pretty amazing. That's a great story, but it tells you how much normal lung tissue that you can spare. I think this is important. The third highlight is convenience. Especially in the situation in Ukraine, the delivery can be done in one session. It's not always easy to come for 5 treatments, 15 treatments, 20 treatments. As one and done. You don't even have to come to image before. You image that day, you place your needle, and then you treat the patient, and it's done. It's so convenient. I had a colleague in Nepal who started doing this, and then a lot of them are of his patients are farmers. They can't leave for 3 days or 5 days and leave the farm unattended, and they don't have the resources to stay somewhere for multiple days. So this is one and done treatment. When you're putting the needle into your tumor, your inherent motion management. You don't have to do with this 40 CT, bellows or ABC breathing. And then, so you don't even have to have a PTV margin. We're just treating the tumor. You treat what you see. And then that you're hitting the target. And, the last point is well-tolerated low toxicity. One of the patients, a lot of the patients that I've treated had prior treatments, whether it be SBRT, chemoradiation, or cryoablation. They get this treatment and then they're like, wow, that was so easy. Why didn't I learn about this before? And then I think as a community, as brachy specialists, we should kind of promote these type of treatments. So the next slide, I think it's important to note that escalated dose is important for local control. You can see, when you give a high enough dose with a BED 120, you get, local control 80 to 90%, for these patients. So you need to have enough dose, and then you'll have good control. And then this is how we do it. So I always emphasize teamwork, within our group, within our colleagues. I think it's very important to work as a team. That's, together we're stronger than each individual. And then I like to show this picture because, I bend over and, work with and help my colleagues, and then they return the favor, back to me. And then, so it is a true collaboration, between our IR docs who help us, especially for the lung, to place the needles, our surgeons, because if there's any complication, God forbid, but they will help to bail us out. And us as radiation oncologists, we work also very closely with the physicists and the nurses and the surgical techs and the therapists. I remember, when we first started this program, putting needles in the lung, I went to Sangjun and our Dr. Park and our nurse Kayla, and I said, I want to start trying to do this more and more. They're like, what? Like you want to put needles into the lung? They're like, okay. And then so we sat and we had multiple meetings on, how to have a SOP for procedures. And then in the beginning, we did a procedure. We kept on building upon it, and we got better and better. And now it's pretty routine for us to do these cases. You also have to have the right stuff. The right stuff is not much, this is the New Kids on the Block. I don't know if you remember in the 1980s, the right stuff. I'm not going to sing this song. Sometimes I'll do it, but we have, I like to say, a studio, in our brachy suite. We have a in-room CT, but most apartments have a CT, or hospitals will have a CT. That's all you need. 17 gauge coaxial needle. I'll show you what that is next. A 4 French catheter that you put into your needle, and then you just have to have medications like Marcaine and lidocaine for local anesthetic. And then sometimes as the patient's anxious, we give them some Versed or fentanyl for pain. But you don't want to heavily sedate these people because we want them to control their breathing. And then when we put the needle, we actually ask them to hold their breath so they're wide awake when we do these procedures, because I'll go into that later. So going into, this is a needle that we don't usually see. I have it right here. I don't know if you can see the camera. So this is the 17 gauge coaxial needle. So this is a needle right here. And then the needle has a internal obturator, you can see right here. And then I don't know if you can see me on the camera. And then you could put it through the middle, and then it's pointed at the end. And then you can use this needle, and under CT guidance, you get the direction, and then you place the needle. And at the end, once your needle is in the tumor, you could put in your treatment catheter. Actually, our therapist loved this treatment so much, he designed this catheter with Best. He didn't get any royalties off of it, but it goes into the main shaft of the needle, and it screws right in, and you can treat through this catheter. That's your 4 French catheter. And then we have a guide wire to a dummy wire in the middle that you can see the depth of where your catheter is if you're all the way in. So this is a really nice system here. So this is our brachyablation procedure. You can see. So the first thing, this is a 53-year-old male that had metastatic HCC, hepatocellular carcinoma, had multiple treatments, including transarterial chemoembolization and RFA, radiofrequency ablation. He had also had an orthotopic liver transplant. And now he develops this right upper lobe metastasis about 4 centimeters. You can see that it's abutting the heart. right here. And the first thing we do is we do a scan. We ask the patient to hold their breath, comfortably, a small deep breath in, and they do it. We do a scan. The scans are 2 millimeters in thickness, and then we do a scan. And then the first thing we look at is like, oh, how are we going to approach this tumor? Is there any ribs we need to avoid? If there's any vessels we need to avoid, and then we develop our trajectory. And then we look at this trajectory, we want to go to the end of the tumor, and then we can measure how long of a needle we need, okay? So that's the first thing we do. And then, so the next step is we do a scan, and then the scan, we measure the distance from the skin to the pleura, and then we put our needle in, make sure it's in the right path, and then avoiding the ribs. And we numb up this area right at the pleura. This is the area that is well innervated, that causes the most discomfort. So we numb this place up, and then the patients are comfortable for the rest of the case. The marking will last you like 4 hours. They'll be numb there for 4 hours, okay? And then so after we numb, we pop in really quickly. You don't want to dilly-dally and then have your needle right against the pleura because you'll scrape the pleura. This is key. And you pop right in really quickly, pass through the pleura, and then you can take your time once you're past through the pleura and do repeat scans to make sure that your needle is going in the right direction. And then you want to make sure you're not hitting any blood vessels. That's the main thing, or major airways. And then, so this is the coaxial needle in place. Looks pretty crazy, like you stab someone in the chest. But this is it. This is the needle in place, and then you can take out this middle obturator and put in a 4 French catheter. Now we develop a luer lock system that goes straight in, and it's a closed system. So we secure everything into place, and then use tape. There's actually a clip. I don't know if you can see it here, but on here you can't see it on the slide, but there's a clip on the needle that goes to the skin surface, and then you tape that, and it holds the needle in place pretty well. And then we start doing our plan. I try to aim for at least 24 gray or higher. I feel like that's the magic number. This patient got 25 gray in 1. You can see this 25 gray is the blue isodose line, but you can see a lot of the tumor is covered in 50 gray in 1 fraction. That's the pink, okay? And then so like people are trying to give, they can't even give 50 gray in 5 fractions for ultracentral tumor, and we can do it in 1 treatment. So this, you get very high dose, very high conformality. The prescription is 25, but most of the tumor, a large proportion, is getting 50 gray. It's pretty impressive. And then so, everyone's like, wow, that's a lot of dose. And then so this is the pre-treatment. You can see 6 months post-treatment. Like, if you did SBRT, 6 months post-treatment, this whole place will be a cloud. You have a sliver of scar tissue. It's pretty amazing. Tells you that, it suggests that you maintain a lot of the patient's lung function. This is another example of a central lung tumor. You can see here, it's a soft tissue sarcoma. This was actually our first patient that we treated at UCLA. It was a patient, one of my former co-residents when I was a resident. He was in Virginia, and he treated the guy with, he had a lobectomy, but he had 3 courses of SBRT and a central chemoradiation field for the soft tissue sarcoma. And then the last course was a SBRT, and he landed in the ICU, for 30 days with radiation pneumonitis. So eventually he developed this solitary lesion, and they're like, what can you do? And he's like, can you brachy this? And then I said, sure, why not? We'll try it. So this is our first case. And you can see here again, this very high isodose line. I think this is like 48 gray in purple. And then 6 months post-treatment, you have, very little scar tissue, that's liver. So you actually see radiographic complete responses, like with SBRT, you're like, oh, did it respond? Did it not respond? At least, the scar tissue is stable. But here you can see a really nice response. And this is our first publication. Our resident, we recently updated. I don't have the data to show you, but this is it was 25 patients, 37 tumors that we treated. And you can see there's variable histology. A lot of the histologies were thought to be radio-resistant tumors like RCC or soft tissue sarcoma. And you can see that the majority of them were ultracentral. Half of them were ultracentral, and a quarter of them were central lesions. And then you can see a lot of them had prior treatment, including half of them having external beam radiation or some cryoablation or microwave ablation. And we had a 3-year local control rate of 96%. We had one failure, and this was because of a patient that had an ultracentral tumor and what was right next to the main airway, and we had to lower the dose. So we didn't give enough dose, and that was the patient that failed. We still have issues, even though we have high local control, they're still failing elsewhere. And I think this is an area looking at brachyablation with different systemic treatments, like especially immunotherapy. It would be interesting. In terms of tolerability, it's very well tolerated. We didn't have any significant grade 3 or greater events, whether it was acute or late. People always ask about pneumothorax, and then if you follow that technique of popping through, and then there's actually now a high, it's almost like spacer. It's a peg plug that when you withdraw the needle, you can insert the plug at the pleural surface, and then that minimizes any risk of pneumothorax. So conclusions: lung brachyablation can deliver very high doses of radiation to eradicate tumor while sparing normal tissue. It's safe and feasible, and it's a convenient procedure, just one visit for many of them with low toxicity. It does require a team effort, and then now we consider it part of our multidisciplinary care in our tumor boards for our patients. We have an amazing team. I believe it's like the Warriors, Golden State Warriors, strength in numbers. I'm from the Bay Area also. So we have a huge team that we work with, and thank you. I think Sangjin's next. Dr. Park.
Thank you so much. It was amazing, and thank you for sharing your experience. We'd have to read the paper, so it's really impressive what you do.
Yeah.
And you can stay at the end for questions, correct?
Okay.
Yeah.
Sorry. Let's go to the first page. Okay. Then I'm going to go to presentation mode. Okay.
Sanjun, your internet is
see my-
frozen.
Hello?
Yes, and June, if you can turn off your video, maybe it will be a little bit more steady connection.
Okay. Let's see.
Okay.
Can you hear me?
Yeah, we can hear you well now, and then share the slide. Perfect.
Okay. Okay. So today I'm going to talk about the lung brachytherapy, the key physics considerations. I don't have any conflict of interest related to this presentation. Some cancers have been treated with various techniques. Here, the and bronchial treatment. As Albert showed that the tissue imaging by the brachial ablation, and then permanent LDR, the CD implant. So today I'm going to discuss and then talk about the equipment QA, imaging, planning, and treatment for these various lung treatment techniques. First, endobronchial brachytherapy. So interventional pulmonologists, they use bronchoscopy to biopsy the lung tumor. So you see this bronchoscope has the three channels, one light and one the camera lens, and then one empty channel. They put the biopsy cable through the channel and then do the tissue sample. But we are using the same technique and place the brachytherapy catheters into this 2 mm diameter biopsy channel. So the Electa and Varian developed intraluminal, the long endobronchial catheters. Electa called the lumen care applicator, and then Varian has bronchial catheters, both 5 French thickness. Length is 140 centimeter, or like a 1 meter or 150 centimeter, those lengths. And then it's going to fit into 2 mm diameter, bronchoscopy, those channels. If you look into detail and very close to this blue lumen catheter, there's depth indicator on the line with the 1 centimeter spacing. And this used for the insertion of this catheter. So ABS recommend that at least 2 centimeter further deeper than the tumor region placed this catheter, and physician read this number through the bronchoscopy camera, and then place the catheter deeper than 2 centimeter. If there is no indicated, there's the line, you can mark at the tip end centimeter or 2 centimeter. Make sure that the tip end is past than the 2 centimeter further in compared to the tumor location. When we receive this endobronchial catheter, the physicist must do the QA. So first, we perform the CT basis QA. So we put it in the dummy wire in the catheter, and then do the CT scan, and then we measure with the source position simulator or the variant case like length assessment device. You can see the marker at the tip end. We can fuse that and verify these dummy wires located all the way to the tip end, and when we measured catheter length, the markers located at the tip end. And also, we can tape this on the gap chromo film, EBT3 film, and then using the electron beam, like a 6 MeV to 20 MeV electron beam, irradiate about the 300 to 400 MUs on the film. And then you can see on the bottom on the film, you can see the shadow, the marker shadow, dummy marker shadow on the film. And then you can program delivered dual position at the tip, and then in a couple of centimeters behind that, you can verify that radiation source can be delivered at the first dual position at the tip. So physicists must to do this QA before treating patient. So the interventional, pulmonologist and radiation oncologist work together and place these catheters, and then we perform the CT scanning. ABS recommends less than 3 and we are using the And
St. John, we don't heard you.
Dr. Park, we lost the connection. Can you hear us?
spot. Yeah.
Okay, great. Okay, let's continue.
So then the physicists import this CT into the planning system and then digitize catheters. And usually the prescription depth is 1 centimeter from the catheter. That's the prescription. And then we use the catheter point basis optimization and normalization. So create catheter point from the starting end point of the tumor location and 1 centimeter from the catheter. We create the catheter point and then deliver the radiation, optimize and normalization. The ABS consensus, they provide a guideline for the endobronchial cancer treatment. For the brachytherapy only monotherapy HDR, we have a 10 gray to 15 gray in one fraction or 14 to 20 gray in two fraction. If brachytherapy used as a boost following EBRT, we treat 10 to 15 gray in 2 to 3 fraction, following up to 60 gray in 30 fractions EBRT. So this prescription try to deliver at the 1 centimeter from the catheters. And we are using the 5 French catheter, which has like, the 140 centimeter. So if you use a regular transport guiding tube, that has 1 meter. And then from the nose to the, the target area is longer than, 40 or 50 centimeter. So you are using 140 centimeter or 160 centimeter endobronchial tube to connect the machine. You have to use the clamping adapter to connect 5 French catheter directly to the machine. So the placement can be done through the nose or mouth, or and then you can remove the bronchoscope, or you can keep the bronchoscope together and then keep the catheter in during the treatment. Question. To treat lung cancer in bronchos, HDR monotherapy was delivering using the endobronchial catheter. According to ABS consensus guideline for the thoracic brachytherapy, which prescription and prescription points are correct? 10 gray in one fraction at 5 millimeter depth or 1 centimeter depth from the center of the catheter, or 20 gray in one fraction, 5 millimeter or 1 centimeter from the catheter. The correct answer is 10 gray in one fraction at 1 centimeter.
Let's wait until they answer.
Sorry.
Approximately 80% answer. You already gave them the answer. But we usually wait until approximately 80% answer, then I'm ending the poll.
Okay, so the
And
next
I will
question.
share the result. Wait. Let's end the poll and share the result. So majority answered B, 10 gray in one fraction at 1 cm from the center of catheter, what you suggested.
Okay, great. It means that everyone pay attention to my talks, so I'm glad about that. Okay, so next one, I'm going to talk about the HDR interstitial brachytherapy, also called the image-guided brachytherapy ablation. Our Dr. Chang, discuss about the equipment QA and then the planning and treatment. So we work together with the interventional radiologist team because their job is that planting this biopsy needle using ultrasound CT guided and put it in the tumor and then biopsy. To be honest with you, like most of brachytherapy physicians familiar about the prostate GYN implantation, right? That's done in our department, the radiation oncologist can do, but this is a little bit high risk. So we work with the interventional radiologist, but it's easy for them. They doing the everyday this procedure. So they put the catheter for us. We place the brachytherapy catheter into their introducing needle. So this one example for usually one or two catheter placed to treat the lung, the cancer area. Sometimes, many needle is, placed there. As Albert mentioned that in our department, we developed these brachytherapy catheters. Interventional radiologist placed this 17-gauge coaxial stainless steel needle into the UCT guided, and they remove the stylet. Then they can put in the biopsy needle for the tissue sample through this stainless steel needle. But we placed the brachytherapy catheter. We designed the French inner catheter, and then place into the stainless steel introducing needle. And then first version, we don't have this male lower lock male cap to secure. So we developed this lower lock cap. And also the problem is the full French catheter, which is 1780 gauge needle, is very thin. So it's easy to break and bend and kink. So we create a lower lock secure using the male cap plug lower lock and secure with the stainless steel needle. But the connection part, we use a 6 French connector. So currently, Elect has 4 French, the transfer guided tube. They have 4, 5, 6 French, but the 4 French to transfer tube also we can not connect directly to here because our diameter of this 4 French brachytherapy catheter is thinner than the Electa 4 French needle. So have to design uter connected to the 4 French and then put the CT mark wire for the imaging value. This 3 different needle. And once we use this 4 French needle, tip end is coincide exactly with the outer stainless steel needle. And then we measure the length with the source position simulator and create the reference length. So before the treatment, before the planning, the therapist and physicist measure together and then double checked with this reference length. So if physician makes using the shorter, place a shorter needle, that's the tip end located in the middle of the coaxial needle, or if they use a longer needle, it penetrates through the tip end because the introducing needle end is open end, so they can do the biopsy. So that's not the stop. So we create the exact needle and then coincide both in the tip end. And because we are using 1 or 2 catheter for the the brachytherapy ablation to treat lung cancer. If a few millimeter, the long measurement, like a 4 French needle is too thin, it's often we have obstructions, and then that a few centimeter or a few millimeter can cause medical event because we are treating sometimes like a nodule target. If you have centimeter of measurement, it can be deliver all the prescription dose out of the target. So just be careful about those. So we have to QA this documentation, and then 2 persons, therapist and physicist, measure together and verify that. Once needle implanted, we recommend less than 3 millimeter CT slice thickness. So we are using 1 or 2 millimeter CT slice. Then we scan with and without dummy wire. On the left side is only introducing needle. On the right side, we put in the brachytherapy catheter with the dummy marker inside. So you can see some metal artifact on the right image at the tip. and that marker is 4 millimeter length. We can fuse with those images, make sure that the tip end is coincide. And also we do the breath breathing. It can create like a discontinued needle, so some artifact for the needle shift. To avoid that, we're using the breath for the CT scan. And then physician control the CTB. So we are not using any the ITB, like the respiratory motion artifact or set up margin to PTB margin, because this needle move together when the patient the respiratory motion breathing, it move together with this needle. The target move together with the needle. So we don't need ITB margin or PTB. We directly control the CTB. Then patient control the lung and bronchus, major big the blood vessel, lip, skin, around nearby target OARs. And then the physicist digitize catheter. When we optimize it, we are using the 1 millimeter step size for the source dual position for the small target. For the prostate GYN treating like 50 cc, 100 cc big prostate target, we are using 5 millimeter step size or 3 millimeter step size. This create the line source, so they're easy to cover. But this long nodule treatment, sometimes we treating only 1 cc, 2 cc small target. So fine step size help create the fonder dose distribution. And then we are using inverse planning, IPSA optimization. We are not using any maximum dose constraint. So when we optimize it in some like external beam, we have like upper bound and low bound. Upper bound to limit the either maximum dose or hotspot in the target, but we are not using the upper bound, the maximum dose constraint. That give us the dose escalation and ablation to the target. So we deliver like the prescription dose to the target, but the mean dose of the target is around like 200-300%. It's very high. And also using the single channel, there's no option to create like a uniform dose to the target because it's the nature of the brachytherapy source. If you have like many, like 20 needles, something to the prostate, you can use like uniform dose to delivery, but because you are using 1 or 2 needle, even it's naturally escalate dose. And then we are using the graphic optimization to fine tune the target coverage and reduce OAR dose. Currently, there is no guideline for the OAR dose for this brachytherapy ablation. So we have been using the SBRT, the AWPM TG101 constraint. This is SBRT, single fraction, 3 fraction, 5 fraction. Most of the interstitial IGBA brachytherapy lung case, we're treating single fraction. We try to cover the 24 grade times 1 fraction. If there is OAR close by the target, it can go lower, and just try to keep under this single fraction dose constraint from the TG101. Our goal is that CTB D90 over 100 or CTB B100 over 95% is our target coverage goal. And then we try to meet the constraint. And as I mentioned before, we developed 6 French connectors. We are using the 6 French transport tube connected to the afterrotor and then delivered radiation. We don't need to use a 4 French transport tubes. So for the dose calculation, because we are treating lung, so it has a lot of heterogeneous. And unfortunately, like, all the HDR, brachytherapy program used basically like TG43 calculation. Everything considered as water, and then for the dose calculation formula we are using. But the AAPM published the TG186 guideline model basis those calculation, the algorithm they propose in the published through the WAPM. The Berian, they create accurate brachyvision, and also the Electa, create, advanced Krebs-Kon engine ACE algorithm to take into account heterogeneous correction into the planning system. And also, in order to benchmark this, the physicists can use the Monte Carlo method to calculate, the correct heterogeneous medium for the long calculation. So we did some study, compare the TG43 versus TG186, how much those going to be different in the target. It turns out we have a 7% higher D90 dose using the TG186 compared to TG43. And also we have higher B150, about 30% higher in B150 using the TG186 algorithm. This is Electa ACE algorithm we are using. So this means that the lung cancer is a high density compared to the water density that has more radiation deposit into the target. That we proved that, so we better use the TG186 for the accurate dose calculation for lung case. And people talk about why not using just the external beam? With the 54 gray in 3 fraction, those calculate with accuracy XB for the heterogeneous corrections. We did that 24 gray 1 fraction with ACE algorithm. It turns out that the D90 using from the IGBA, the brachytherapy is 20% higher than SBRT. And the CTB mean dose is about 200% higher than SBRT. So we proved that we can escalate dose and they delivered high dose to the long term using the IGBA, the brachytherapy technique. Okay, questions. I'm not gonna give you answer first. Which of the following algorithm has the greatest error in long brachytherapy dose calculation? WAPM TG43 formalism, Berian accuracy BB, Breed's basis transport equilibrium, Electa ACE algorithm advanced Krebs-Kon engine, Monte Carlo method MCMP, electro-gamma shower, or GENT.
Thank you. So we will wait. So currently we only have around 40%. We'll wait until 80% answer. Well, I'll let you know. You probably can see it on your screen. Can you?
I cannot see the answer, the data.
So we have
Okay.
80% answering now. So I'm gonna end the poll and share the result. So majority answered A, APM TG43 formalism has the highest, greatest error.
Yeah, that's the right answer. Unfortunately, still, the way people using PGF, that's it's working with prostate because there's not much.
We lost connection. Sorry, Dr. Park is on a cruise currently, enjoying his wedding anniversary, and he's giving a lecture from the cruise. So his internet connection is not very good. We hope he will rejoin us. But he was trying to say that TG43 is the correct answer. So that's the algorithm that's currently used for prostate, GYN, brachytherapy. And that's appropriate to use because in those areas, there's less heterogeneity in tissue. But full on, as Dr. Park showed, it's important to use more accurate algorithms. As he showed, there are differences, dosimetric differences. And so it's appropriate to use TG186. Maybe while he's joining, we can look at the questions in the chat. Yeah. Dr. Shepherd, do you want to read some of the questions?
I saw several questions, but of some questions, Dr. Chang answered on the chat about size of tumors. If we right understand, you treat all sides. You use several catheters if the tumors bigger than 2 centimeters, maybe. Yes, if it's correct answers. And also, people ask about can it be performed there are 2 or more tumors if you have several tumors on the lungs tissue? Do you use brachytherapy or propose other method of treatment?
Yeah, so I think for larger tumors or more tumors or even irregularly sized tumors, I think it's just using the standard principles of brachytherapy. Well, if you need to cover or you need more conformality, having additional needles or catheters will help you. So that's what we do. Like for larger tumors, if there's not enough coverage, we'll just add more catheters or to cover. There's not a per se a limit on the size, but or how much you can treat is more of your dose constraints if you're able to meet your dose constraints. And then, what we use kind of like the TG 101 dose constraints because that's the best that we have, I guess, that's accepted. But they're actually pretty conservative dose constraints, and if we need to push them, sometimes we'll push them more. So yeah, and then there was another question about prior radiation, and we do take prior radiation into account. Like I mentioned, there was a patient that like had an ultracentral. That was the one that failed. Where they had a lot of dose before to the central airway, and we were concerned about causing a fistula or perforation of it. So we had to decrease the dose. But it's on a case by case basis, and then you have to weigh the benefit of pushing the dose versus the risk of causing a complication. Yeah.
Dr. Chang, is there a limit how many needles you can actually insert? Would the risk of pneumothorax, let's say, increase with the number of needles?
Not really. I mean, we've done like up to 4 needles, I guess.
Okay.
But so that's also a good question. I think when you think about treating a patient, you can treat multiple lesions. Ideally, you don't want to like let's say in the right lung, there's 3 lobes, right? The right upper, middle,
Right.
and so you don't want to go and cross into different fissures. Because let's say you cause a pneumothorax, and then you like if you collapse one lobe,
Right.
the patient's still going to be fine. But if you put a needle through multiple fissures or multiple lobes, you have the possibility of collapsing multiple lobes, and you can compromise the patient's oxygenation status. So that's an issue.
Okay.
Also, like treating bilateral, like if the patient has multiple, like one lesion on one side and another lesion on like the other side, we'll split up the sessions into 2 separate visits, instead of treating everything in one day, because that you can, cause like bilateral pneumothorax, and that's probably not a good thing for a patient. Yeah.
That's devastating.
Yeah.
And another question I would like to ask, if there were any failure modes, has it been a case, let's say maybe you had some rib obstruction that you cannot get through inserting the catheter?
Usually, we'll get through, like, there's a way. You don't always have to be directly in that plane, you could be non-coplanar, and then you can, go sup or inf and avoid the ribs in that way. Yeah, so usually you're able to avoid the ribs in some way. And then I saw that there was a question. Oh, there's another question. Patient's position. So more anterior lesions, we just have them supine. If it's like posterior, we'll have him prone. Sometimes we'll angle the patient up, or down based on, a way to, this is a question that answers, this is an answer. Like we'll have him like right side up more or left side up more, because it will help to open up the space better, in between the ribs. And then, so positioning is kind of important. The fixation, we use pretty much tape, and the clip system works. The system that we have works pretty well. If there's any question, a movement, a catheter movement, we'll rescan. And then there's times we do that just to make sure. But this system, believe it or not, it works pretty well for the for immobilization and needle migration. I think you asked, can we use ultrasound? The issue is like the lung, is a organ with a lot of air, so it doesn't transduce the ultrasound that well. But we do use, like we apply the same technique in the liver. We've done kidney ablations the same way, or even METs in the abdomen, or inguinal METs in the pelvic nodes, and we'll use the ultrasound to guide, like a transabdominal ultrasound, probe, where to go about this, and it works pretty well. Yeah.
Okay, that's great. And is there a risk to puncture, let's say, near organ, let's say heart?
Yeah, I mean, there's
That
always a
risk.
risk. That's why, I mean, I think you have to be mindful of what's ahead of you in the needle trajectory. And then one thing that's helpful is on the needle, I don't know if you can see my camera. There's like
Yeah.
different markings. You can see like each marking is a centimeter. So we know like, approximately how far we can advance a needle before we come close to an organ. And then we rescan once we're close. And then, yeah, we try to avoid like any vessels or any organs that are critical. Yeah.
And what you showed in the toxicity wise, it was very low, grade 3 toxicity. So great job. That's
There was
quite
none.
impressive. Yeah.
Yeah.
Yeah,
I
there was
think,
zero. Yeah, 0%.
I think that's one thing is like when you compare like all the other techniques, I'm not just saying SBRT
SBT.
but even like cryoablation, like our colleagues do, or micro, like some of them end up in the ICU after, no kidding. But our patients that have undergone this, they go home the same day, and they'll call and they're like, "That was amazing, it was easy." The hardest part of these treatments is if it's a posterior tumor and the patient has to lie prone. That's where it gets uncomfortable, because they can be doing it 2 to 3 hours. So after we put a needle, when we're planning, we'll try to sedate the patient somewhat after, to make so that they're not as wide awake after the needle placement and having to lie prone, because a lot of them can't lie prone for a long time. And they start
So you mentioned few hours. So how long is the procedure from beginning to end?
The procedure placement of the needle is like maybe 20-30 minutes.
Okay.
The planning, we have, like for us, like we work with IR, so we'll implant in one side of the hospital, and then we have a different building or departments in it. So we have to transfer them through tunnels and everything, and then we have to wait for the planning. So the planning can take sometimes half an hour to an hour. So after everything's said and done, it's like 2 hours. And if they're prone the whole time, it's uncomfortable for them. But the patients that are supine do pretty well.
Okay.
Yeah.
Thank you. Thank you
No
for
problem.
these answers. Serhi, do you have also a question?
Yes, I do. Thank you very much for this great presentation. Honestly saying that when the internet connection was bad, I was feeling that like these are very valuable knowledge, and that even give a flavor like how much I would like to continue the presentation. I do have a question about the team building. So, for example, you have to have like, I think one of the challenges is to start, because it looks quite dangerous. So how much of knowledge about brachytherapy surgeon who help you needs to know about, radiation? Do they have some rotation with you, or they are treating from their side as you said, it's like a stabbing someone in the chest, and you are treating from your side as a radiation oncologist, but you don't need they don't necessarily know about that this will be using for radiation, and you cover that part, and they are treating the surgical part.
Yeah, that's a good question. I think so the first time, like our first patient, you saw the first patient. So I went to her and I asked them, I was like, you guys put in needles all the time in these patients, and then you do biopsies, lung biopsies. Can you put in a 17 gauge needle? If you can get a 17 gauge needle into the tumor, especially in the center of the tumor, I could develop a treatment where using where we can load radiation directly into the tumor. And I think it would be pretty. So that's how I approached it. And they're like, yeah, we could get a needle and there should be no problem. And then so they didn't necessarily, have an idea, like, what about radiation? But so now they always ask, oh, how big of a tumor can we treat? I say we can treat the whole body with one catheter if you want. It's just like what is around the tumor, like what you guys are asking. How big of a tumor can you treat? It's like, how can you respect, your dose constraints? So that's what I told them. So sometimes we'll have to put 2 or more or 3 or more, and then they understand that. In terms of getting them to buy in, I think in the beginning they're like, oh, they just are like, okay, we'll put in a needle, we'll put in a needle. And then afterward, they see the patients, they do really well, you know. And then they're the one, like our interventional radiologists, they're also our diagnostic radiologists. They read the chest scans. They're like, wow, this is amazing. Like you actually see a radiographic complete response. And then they see the patients after and they're doing well. They're like, we should be doing this more often. So I talked about our multidisciplinary tumor board. I don't even go to that tumor board anymore. They go to it and they're like, we should do brachy. Why can't we do brachy on this? We should do brachy on this. And they're the ones that are sending us the patients though. For this.
I
Yes.
also, oh, sorry, Sergey, please continue.
Thank you. Thank you for the answer. I did have one more question. So Dr. Park showed us the comparison of V20. I think there was a publication even on this, but maybe you also can comment since you are not using ITV as I understand, or maybe you're using but much smaller. Can you comment on the percentage of comparison of volume being treated with SBRT and
it's going to be a lot less than SBRT. That's the huge, benefit of it, especially the low dose. Like if you look at the, V20 or even like the very like the 5 grade, with SBRT you'll bathe almost the entire lung, with it. Brachytherapy is, you're treating from inside out, so you spare a lot of the. That's why I think, like in radiation oncology, we're getting more and more involved in metastatic disease, like, for local control combining with systemic treatment. And I think this is an amazing treatment because you're not burning a bridge for a patient. You provide them with more options. And then you look at immunotherapy. I mean, sometimes immunotherapy works, sometimes it doesn't work with radiation. But when we use like our beam techniques for immunotherapy, it was always, I never proved this, but like you learn in radiobiology that lymphocytes are very radiosensitive. 2 gray, will wipe them out. So when you're using SBRT or even IMRT every day, you're delivering 2 gray, or more to your circulating blood system, widespread. You're not helping yourself with an immune response. So I think brachytherapy is much more conformal, much more localized. You can spare the circulating and like circulating cells. I think we can look at it with immunotherapy to see if that can be a better combination.
Are you doing any trial? Have you started any trial?
We did. We had a
Combining.
trial actually in GYN where we used this type of technique not just for lung, but anywhere in the body. And it was for
Mhm.
patients with metastatic or recurrent GYN
Mhm.
cancers that couldn't undergo chemotherapy. And then we treated 15 patients. It took us a while to open the trial. And then the patients did amazingly well. Like there were patients that were recurring every 3 to 6 months or to a year that had multiple recurrences, and they came to us and we treated their dominant lesion, and they were free. They're still free of disease, like 3 years out. But unfortunately, our sponsor at that time was AstraZeneca, and they had another trial, like the CALA trial. You guys are probably aware of it, looking at immunotherapy with chemoradiation and brachytherapy and locally advanced. And that was a
Mhm.
negative trial. So after that trial, the
Mhm.
data, they're like, we're done looking at this combination with radiation and GYN cancers. So they shut the trial down. But
Unfortunate. That's
yeah,
unfortunate.
but the
Yeah.
patients did really well on that trial. We always commented on that, my colleagues and I. Yeah. And then
How many patients did you accrue
I
on
think
that?
we treated close to 15,
Okay.
and we did Durva and Tremi on those patients, and then they did really well. Yeah.
There's so if Dr. Park cannot join, I have his slides, and do you do also lung LDR? Do you
We
treat
don't
it?
do a lung
You're
LDR.
doing okay.
Yeah,
So you
but
cannot really comment on those slides. That's okay. I think maybe some other day.
oh, he's
He
back.
may
Okay.
be joining.
Yeah, I'm sorry for the unstable
Oh,
network
okay.
connections. Yeah, so let me try that to finish the last, part, and let me share.
It's perfect timing, actually. We had some Q&A, and then you just joined. That's perfect.
Right. Okay, can you see my screen?
Not yet. It's a bit delayed, but we are waiting. Yeah, now we see it. Yes.
Okay, so I'm going to talk about the last part of the permanent seed implant, uh, uh, BLDR, very low rate therapy. Actually, the first two endobronchial case in literature we provide UCLA, but this I learned from when I working as a fellow at the Brigham and Women's Hospital at Boston. So this long after wet resection, sublobar resection, remove the tumor case. And the physician used these isotope, low energy isotopes to treat it. So VLDR means very low dose rate, less than 0.4 gray per hour dose rate delivered to the target. HDR, we could deliver over 12 gray per hour dose rate. So using the dose iodine 125, palladium 103, cesium 131 has around like a 20 to 30 kb, very low energy. So we using those one. It's you can create the strand seed with this individual seed, or some vendors sell the strand or mesh type, and then you can the strand seed you can create the kind of mesh type the applicator in the OR. So before the implantation, physicists order the number of seed or strand before the implantation, and we try to receive at least 1 day before the implant date for the calibrate assay and then source calibration. This and the ones in the AB WPM has a recommendation over 10% of the total number of seed or 10 seed, whichever is larger. We need to do the assay and calibrate the verified source strengths. Usually the strand seed or the sterilized strand source we receive, and it's difficult to calibrate the assay with the sterile well chamber, and it's many hospital program doesn't have the sterile well chamber. Also we couldn't difficult to get the the calibration coefficient from the ADCR using the strand seed. Most of the time in a place with a single seed calibration. So we can order equal to 5% of total seed or 5 seed, whichever is fewer. Then we can order non-stellar loose seeds, not the strand seed, and then calibrate to verify the source activity strength. The average, the source activity less than 3% different, we don't need to do anything, but between 3 to 5%, still we can use it, safe to use it, but still need to investigate why we have this high discrepancy. Or 5%, better not to use it, but this is performed in the OR or before the day of implant. You need to consult with the physician about using our measured the source activity instead of the vendor activity from source certificate, because that's what we measure, and then try to find out the discrepancy, contact with the company, and then find out the why this have over 5% in the discrepancy. In the OR, the physician kind of suture and it put it in the shielded ring. One end has the curved needle, and usually 10 seed in the one range. Source is about 2.5 millimeter length, diameter, so that has 1 centimeter apart. So we can kind of physician create this mesh type, and then weave through this bicolor mesh. It's a bio observed mesh, and then they create mesh applicator. So how to determine the spacing? So based on the current activity and the prescription dose, like 120 gray or 100 gray, and to the 5 millimeter above and below for this mesh, the plane of implant, and we have known activity, and then we can control the low spacing to deliver 120 or 100 gray to 5 millimeter from the mesh. So we can have high activity, have like wide spacing, or have low activity source. We have more spacing, and then deliver the same amount of those to the prescription depths. And the thoracic surgeons, when they do the wedge resection, they deplate lung and then remove the tumor, and then they put the staple staple to put together, and then based on the pre-calculation, create the mesh, we put it in there, and then using the surgical clip, and then implant the lung. Patients, we did, and then after the implantation, we just did the radiation safety survey, and then source of or like a contamination perform measure on wonder from the patient. We have the radiation safety instruction provide to the patient, and how long they're going to keep the distance to their family to reduce the exposure to the family. And 1 month after, the patient come back to the hospital and then do the post-implant CT scan, less than 3 millimeter CT slice recommended. And then we put it in this CT image into the planning system, detect each seed based on how many seed we know how many seed implanted, and still using the TG43 calculation formula, and then calculate the dose distribution around the target area. And other technology also developed using called the Shiba dot, which is palladium 103 source attached in the gold disc, can be placed into the wedge resection cavity. That one clinical trial is going on right now. Not only the permanent CD implant, and if the OR has shielded OR, you can still use the HDR technique, use a hem applicator, which is usually used for the skin treatment. But this sterilized hem applicator can be placed into the resection cavity and then delivered radiation using HDR technique. The question, for the long mesh brachytherapy using sterile source strand, non-sterile lucid were ordered for assay. According to WAPM, oh, I can see, okay.
You can
WAPM,
close it.
yeah, WPM low energy brachytherapy source calibration working group report. How many seeds should be assayed? Usually this question for the physicists, and we're taking care of that. So it's difficult to answer by the physician. It's all total seed or 10 seed, whichever is larger, fewer, equal to 5% of the total seed, or 5 seed, whichever is larger. The key point is the sterile source strength we are using, not the non-sterile seed, and then sterilize it.
So we have around 66%. So wait a little bit. Let's wait till 80%. Yeah, we have 80% participating in the poll. I'm ending the poll and sharing the result. So the answers are split, but majority answered B actually, equal or greater than 10% of total or 10 seats, whichever is fewer.
It's very interesting about the answer. Okay. Key point is that let me show the answer first. Equal to 5% of total seed or 5 seed, whichever is fewer. Because we are
Fewer.
using
So,
sterile source
correct
strand
answer is
and
D.
other
Yeah.
non-sterile, yeah. D, yeah. If answer is A, is going to be we're using the non-sterile seed, like in iPlag, or then create applicator. You can sterilize the applicator. That case, we are using over 10% or tested whichever is larger. That's the common like prostate seed implant or iPlag seed calibration. But when we using sterile source strand, then we are using 0% equal to 5% or 5, whichever is first. The answer is D. Okay, in summary, brachytherapy plays important role in the treatment of lung cancer. Brachytherapy is used as monotherapy, brachy alone, or boost following EBRT, or in off-rover lung, or in combination with the surgery. And variety of treatment technique like intraluminal, monocytic implant tissue applicator can be used to treat the thoracic tumors, and brachytherapy involves close collaborations with the interventional other departments. Yeah, thank you for your attention. This is all I have.
Thank you so much. Thank you.
So I
And we
apologize
are
for the
really
bad,
sorry for
introduction.
technical issues and difficulties. But we are really, really thankful and grateful to you for giving us this lecture while on your wedding anniversary cruise. Thank you for supporting Ukraine and dedicating this time to making the lecture and giving this talk. And I think he lost connection.
Okay,
Maybe
I'm
we'll
back.
open the floor. Oh, he's back. Excellent. We will open the floor for questions and discussions. If you have any questions, you can turn on your microphone, camera, and ask a question, or you can type it in the chat. Oh, great to see you now.
Yeah.
Okay.
I also have one questions because I want continue questions about Tim. How you win your surgery because the solitary lesion in the lungs is very frequently will be operated in our clinic with laparoscopy, for example, and how you manage this patient to the brachytherapy.
The question for the LDR, the seed implant after the wedge resection.
I think the question is
No,
to Dr. Chang, right? How do you win your surgeons?
The question is, how do I work with the surgeons, or
When
yeah.
the surgeon to actually do the brachytherapy, but those cases are mostly central lesions. Are they operable?
yeah, so most of them are not operable.
Yeah.
And then a lot of them are metastatic. And then so I think for localized like T1, T2, disease, like the surgeons will tend to want to operate on those. So a lot of these metastases, there's some discussion, but I think they shy away more from the metastasis because they'll just keep on operating and operating on these, especially some of these have been heavily pre-treated that like you saw half of them been pre-treated already, so they're not going to operate on these patients. Yeah.
Right. So that's easier fight. Yeah.
Yeah.
And I also want to ask about if the patient has, for example, metastatic lesion on the lymph nodules in mediastinum, and for example, solitary lesion on the lungs tissue. Do you use the combination for external beam radiotherapy for lymphonodules and brachytherapy for the lesion, or you use brachytherapy as boost as well?
No, I mean usually the ones that we've treated some mediastinal nodes, like especially if they're recurrent after prior radiation. But I think if the patients are getting beam radiation, usually they'll just get beam radiation, alone. And then, but there are patients that, like where it's difficult to get enough dose, we'll do like subcarinal lesions. We'll do an endoscopic approach, like Dr. Park shows, but we'll also try to bury a needle, or a catheter through the carina directly into that node. And then that's done using a biopsy needle where it creates a path, and we're able to introduce that 5-French catheter under the scope through that path. So we've done some cases like that. It was pretty cool. And then the patients responded pretty well. But usually, if they're getting some beam or chemoradiation, yeah, we don't do brachytherapy in combination with that.
Mhm.
It's an idea, but I think it's getting people comfortable first, one thing at a time.
Yeah.
Thank you very much.
Does any clinic except for UCLA do this procedure?
I think there's been talk about more and more people wanting to do it, and then we've
Right.
been multiple fellows, but I think there is a barrier kind of to do it.
Yeah.
But
Yeah.
I mean, it works amazingly well. Every time I give this type of lecture, everyone's like, "Wow," and the results are, really amazing. I'm not just saying
Impressive.
that
Yeah.
because we do it, but it is a great modality. Yeah.
Yeah, that's that. And as you mentioned, it can be really cost effective for Ukraine, right?
Yeah.
And many centers in Ukraine do not have motion management equipment. So SBRT for lung, it's quite prohibitive. So brachytherapy can be an option. They just need to find the team, create the team, train the team to do this, right?
Yeah, it's not, I don't think it's like you don't need much to do it. And then, like it's one visit, like especially with the logistics now in Ukraine, unfortunately, I think it will help a lot of patients. And then one thing my I have that friend and colleague in Nepal. He was telling me in Nepal we have like one center, with 3 linacs for the whole country or something like that.
Yeah,
And
yeah.
then he's like, having this technique, it's helps us a lot. We have like people that can't stay here, for multiple days for treatment, and then you get it done in one treatment, and it's effective. Yeah,
Yeah.
so it kind of changed them. I think it makes a big difference.
That's great. I also have a question to Dr. Park. Dr. Park, you talked about heterogeneities. Have you done the comparison with using TG186 and SBRT and looked also at the low dose? And that's something similar that he asked. I think low dose, that's where in a LAN, that's where Brachy would win, right?
Yeah, but unfortunately, there's no the commercial software to sim like calculate for those LDR algorithm and then accuracy bracket
Okay.
vision. That's for the
Right.
only HDR Iridium 192 source. But if we do, there's a couple of publication using the Monte Carlo using the MCMP or GENT, they calculate the seed distribution. But unfortunately, there is no the commercial software, but the
Got it.
heterogeneous correction for LDR. Yes, now.
And then another question is for endobronchial HDR. We performed it also at Mayo Clinic when I was a resident. I remember having people or the team made a mistake of length of the catheter, and this mistake can be consequential because you might mistreat the location.
Yeah, definitely.
Instead of a tumor, go somewhere close to esophagus or something similar, right? So how do you prevent this? How you showed some measurements, double checking, but maybe more robust way of not making that error overall.
Yeah, there's error from the long measurement because easily kink.
Right.
So you're gonna need this reference
Yeah.
length for catheter. And then, for the imaging, another error is that when we digitize it, if the dummy wire came out or not all the way in the T-band, you can
Right. And
misdigitize the
that's what
T-band.
happened.
Yeah, so those two things. So when you put the dummy wires, make sure that that's all the way in, how much is sticking out the other ends, connect, verify that. So that's proof that dummy wires, Marco wires all the way to the tip, and then you have a reference length, and then those two can avoid the mistake. Yeah, it's very sensitive. You have centimeter off, and then you can be missed the target easily. Even try to give like a 2 centimeter margin, around the tumor area. So it's very critical. Have digitize it or those can.
Okay, thank you so much for that
this
answer.
I do have one more question about quality of brachytherapy. So you mentioned obviously the geometry is very important, but also maybe not for lung, but for other localization. Do you use any type of in vivo dosimetry to check the dose that you calculated on a skin or elsewhere? Maybe on a phantom also to check that your algorithm calculates dose correctly.
Those like the brachytherapy before you start with the end-to-end test. Put it in the pantome and then put the TLD or gap cloning film and then deliver it known amount of radiation dose. We're gonna scan the geometry and print so we can verify that the final dose delivery. But I mentioned that there's no heterogeneous corrections. Assume put it in everything in the water bucket, and then do the delivery and the measure. That's how we're going to verify it. But it's difficult to verify this long geometry with heterogeneous correction, without heterogeneous correction. Or all this, the different density material around that measurement to those with the TLD film is difficult, challenging. So, but we do verify that with gap TLD or gap chrome film.
Yeah. Thank you so much. Thank you for your answers. Thank you for excellent lecture. And we are sorry for technical issues, but I think we got the the whole procedures and different types of procedures. Thank you for covering it very thoroughly for LAN LDR and HDR. We want to say thank you to our speakers, and our last lecture of the course would be next week, also Tuesday at 20 Kyiv time. So we're waiting for you there. It will be on brachytherapy or iPlaque brachytherapy LDR. See you
Thank you.
next
Thank you
week.
very much for your support. Thank you for very interesting lectures.
Thank you.
Thank you.
Thank you.
Bye.